Welcome to The Explainer. Today we are unpacking a highly provocative 2026 paper published in JAMA. This research, brought to us by Dr. Ezekiel Emanuel, A. Baker Butler, Neil Khosla, and Vinod Khosla, directly challenges the absolute most deeply held assumption in modern medicine. The authors bring forward a literal mountain of descriptive data to ask one incredibly consequential question: will autonomous AI actually exceed AI-aided physicians as the best standard of medical care? Let's get right into it.
Here is our roadmap for today. We'll cover the prevailing medical AI myth, look at 5 core cognitive tasks, explore the human-AI hybrid paradox, discuss the trap of algorithm aversion, review the caveats, and wrap up with medical care by 2030.
All right, Section 1, the prevailing medical AI myth, or what we can call the assistive assumption.
Okay, let's dive into this. The medical establishment has a very clear, firmly entrenched stance. The American Medical Association actively calls this technology augmented intelligence, and they do that specifically to keep the focus strictly on an assistive role. Prominent voices like Dr. Bob Wachter have argued that the absolute highest tier of care will always be an AI-aided physician, while AI-only care, well, that would basically be medicine's economy class. The baseline assumption across the board is that AI is just a tool to help the human doctor, nothing more.
But here is where the source material flips the script. Emanuel, Baker Butler, and the Khoslas completely disagree with that establishment view. They impartially present a radical thesis. For cognitive medical functions, autonomous, AI-alone medical care is likely to be vastly superior to physician-only care, and crucially, superior to physician-AI hybrid care. They argued the establishment actually has it entirely backward.
Moving on to Section 2. 5 core cognitive medical tasks and exactly where AI dominates. To back up this bold thesis, the authors drop a massive amount of data comparing AI to human doctors across 5 fundamental cognitive medical tasks. According to the research, large language models, or LLMs, are already rivaling or outright outperforming licensed physicians at these exact functions. We're talking about eliciting patient information, establishing a differential diagnosis, specifying diagnostic testing, prescribing treatments, and managing ongoing chronic diseases. Let's look at the actual descriptive data behind these claims, because it's pretty wild.
First up, eliciting information. You might naturally think humans are far better at talking to patients, but in a study using 159 simulated case scenarios, Google's Articulate Medical Intelligence Explorer, or AME, was judged to be significantly better than actual physicians at eliciting patient complaints. There's a staggering gap here. The AI received a 97% favorable rating compared to just 50% for human physicians. It's incredibly counterintuitive that a machine is already demonstrating better bedside manner and history-taking than real human doctors.
Well, what about diagnostic testing? When instructed to stay within an $8,000 budget on 56 real-world, complex cases, the Microsoft AI Diagnostic Orchestrator reached the correct final diagnosis over 4 times more frequently than human doctors. Let that sink in. And it did so at a notably lower cost. The AI's diagnostic cost was $2,396 compared to the physician's average of $2,963. It was more accurate and much cheaper. That is a combination that could fundamentally change hospital billing and patient outcomes forever.
Now, what's really interesting about this is the massive gap in prescribing treatment. When recommending guideline concordant treatments, Google's AME prescribed the appropriate treatment 90% of the time. Primary care physicians hit that mark only 37% of the time. Think about that drop-off. And it's not a one-off. In a totally separate study at Cedars-Sinai using real patient cases, AI again provided optimal treatment recommendations at a significantly higher rate than human doctors. The data overwhelmingly points to AI dominance in these heavy cognitive tasks.
Section 3. The human-AI hybrid paradox, or when humans ruin the math.
This brings us to the most mind-bending, counterintuitive part of the research. A 2024 meta-analysis looked at 106 different experiments involving human-AI hybrids. The researchers found a stark, undeniable mathematical reality. When humans alone are better at a task than AI alone, creating a hybrid team improves overall performance. Makes sense, right? But when the AI alone is already better than the human alone, deploying a human-AI team significantly worsens the performance compared to just letting the AI work autonomously. When the machine is smarter, putting a human in the loop doesn't act as a safety net. It actively drags down the success rate.
And this brilliantly illustrates exactly what we're talking about. Look at median diagnostic reasoning scores on real patient cases. ChatGPT-4, operating entirely on its own, achieved a remarkable score of 92%. But when licensed physicians were given ChatGPT-4 to use as a tool, that much-praised hybrid model the establishment loves, the score dropped to 76%. The highly trained human experts didn't help. They actively degraded the AI's performance by 16 percentage points.
Let's move to and see how this builds with a really fascinating historical analogy: chess. Back in 1997, AI beat the human world champion. By 2005, a human alone won against AI for the very last time. For a while after that, human-AI hybrid teams dominated the game. But as AI just kept improving, the humans eventually became a liability. By 2017, autonomous AI entirely surpassed even the most skilled human-AI hybrid teams. Emmanuel and his co-authors argued that medicine, while infinitely more complex than a board game, is following this exact same evolutionary trajectory.
Section 4. The Trap of Algorithm Aversion and Why We Fail the AI.
So why does this happen? Why on earth do highly trained doctors ruin the AI's math? It really comes down to a behavioral science trap called algorithm aversion. Basically, we inherently distrust algorithmic advice, even when we are explicitly told the machine is statistically better at the math. And what's truly fascinating here is that this aversion is consistently highest among high-expertise decision-makers, like expert physicians. Sure, they catch a few of the AI's errors, but they end up introducing far more of their own errors by unnecessarily second-guessing the machine. Furthermore, the paper notes a growing, dangerous risk of de-skilling, where doctors' baseline skills slowly erode over time as they rely on AI, making their interventions even more detrimental in the long run.
All right, Section 5. Caveats and Implementation Barriers. It's time for a reality check.
Now, to be completely impartial, we absolutely have to look at the limitations. The authors are not claiming that autonomous AI is ready to take over your local hospital tomorrow. There are severe, real-world barriers. First, many of the current studies are just text-based simulations. They lack the chaotic, messy reality of a physical clinical interaction. Second, AI is strictly limited to cognitive tasks right now. It literally cannot autonomously perform physical procedures. No surgeries, no deliveries, no colonoscopies. Humans are absolutely required in the operating room. And finally, we can't ignore novel, systemic tail risks that human doctors just don't have. Things like sudden internet outages, large-scale cyber attacks, and unpredictable AI hallucinations. Section 6. Medical Care by 2030 and the Urgent Future.
Despite those very real barriers, the trajectory is crystal clear. So, the crucial point is this. Emmanuel and the Koestlis conclude that by the year 2030, this transition point will be upon us. Superior autonomous AI will likely be ready to be deployed for real-world cognitive tasks in many medical workflows. They argue that policymakers, medical boards, and legal systems need to urgently prepare for a new reality, a reality where the safest pair of hands for your diagnosis might actually be an algorithm.
We've looked at the descriptive data, we've unpacked the paradox of the hybrid model, and we've confronted the reality of algorithm aversion. The medical establishment really wants the AI to stay in its lane as an assistant, but the data strongly suggests the AI might soon be the lead physician. So, I leave you with this. By 2030, when you or a loved one are sick, will you trust the doctor or the algorithm? Thanks for joining me on this explainer. See you next time.